Hi nurselings! In this video, we're going to talk about one of my favorite subjects, diabetic ketoacidosis. At first glance, this is a really complicated subject, and a lot of students get really intimidated just looking at the title. Hopefully, I'll be able to break it down for you in a way that will help you understand. And not only that, I'm hoping to give you some tips and clues for the things that you might see show up on an exam. So let's dig in. Diabetic ketoacidosis is the most serious metabolic complication of type 1 diabetes. In the same way that a hyperosmolar hyperglycemic state is a very serious complication of diabetes type 2. The big difference here is that in diabetes type 1 and in DKA, the patients experience an absolute insulin deficiency. Because there's such a severe deficiency in insulin, clients develop these four main conditions. The first is Glycosyria. If you watched my videos on HHS or on the 3 Ps, you understand where that's coming from, but we will talk a little bit about it in this video as well. One of the other conditions, severe hyperglycemia. This makes sense if you have an insulin deficit. There's nothing in your body to help the glucose that's in your blood get into the cells or to help store glucose as glycogen in the liver. So it's going to build up in your blood. One of the other conditions is an increase in lipolysis. Again, that makes perfect sense. You've got all of this glucose in your blood that your body is unable to use because of the insulin deficit. And so it's going to go after the fat cells to try to break them down. And remember, we talked about how that excess insulin is stored inside of those triglycerides. If you need a refresher, check out the video on insulin and the body. And then this is the really big kind of identifier here, this increased ketone production. And obviously these two things are related. We know that when we have an increase in lipolysis, the body releases ketones. And so you have this kind of buildup of ketone in the body. And this buildup of ketones is what causes ketosis. And then this is the part where we can connect it to some of the other things we've learned about, for example, acid-base balance, in that increase in ketone will also cause an increase in the hydrogen ion load. And if you remember from the videos on acid-base, it's the hydrogen ion that's responsible for increasing the acidity in our pH. So if we have an increase in hydrogen ions, we're going to have an increase in acid to the point where, in this case, we develop metabolic acidosis. So let's talk about what can get a person to a place where they're experiencing an absolute insulin deficiency. One of the main triggers, and the one that I see most often, would be infection. And that's because when your body is fighting off an infection, you have a release of glucocorticoids and some of the other counter-regulatory hormones that we talked about before. And we talked about what those counter-regulatory hormones do. They love to build up and kind of hoard the glucose in the blood. And so when you have these counter-regulatory hormones increasing and kind of taking over, they're going to cause gluconeogenesis, they're going to cause glycogenolysis in the liver, and both of those are going to, again, they're going to create even more glucose and add that to the blood. So now not only do we have an insulin deficit, now we have the body actually creating more glucose. And you can see how this is a recipe for disaster. Just in case it shows up on a test, one of the other things that's released during an infection or any kind of fight or flight reaction would be your catecholamines, your norepinephrine and epinephrine. And if you remember from the video on counter-regular hormones, epinephrine is actually one of those. It increases glucose in the blood because it's preparing your body to fight. You need that energy in the blood so that it's ready to be used. And so eventually, and you remember in type 1 diabetes, patients have very, very little endogenous insulin in their body. And so when something like this happens, you've got all this increase in glucose, then the body eventually ends up using up what little insulin it had. Whatever was there that was kind of keeping the body going for years has now all been used up in an acute episode, and you have absolutely no insulin left in your body. This is really, really important because this is one of the big differences between diabetic ketoacidosis and a hyperosmolar hyperglycemic state. That absolute insulin deficiency is what allows the acidosis to occur. Don't worry, we'll talk about that a little bit more. Before we go on, I think it's really important to note that there are other things that can trigger an imbalance between insulin and glucose in a person. And you just remember that this person already has diabetes type 1. They have diabetes type 1. They've probably been living with it unknown for a number of years. They just have never hit this place where something increased their glucose load, or where the demand for insulin would have been so high. Now they've hit that place, they've used up all the insulin they have, and they are in an absolute insulin deficit. How else can this happen? Things like MI, trauma, an acute GI disease. And you remember that Cushing's disease is an increase in cortisol or glucocorticoids. And then severe stress. This is something that can kick diabetes type 1 or can kick DKA off. If you have a sympathetic nervous system response, again, you're going to have a release of these catecholamines. Again, you're going to have an increase in glucose and an increased demand for insulin to use that glucose. A lot of the times that moment where suddenly the body's demand for insulin has increased, a lot of times the reason for it goes undetermined. We don't know what has caused it, but in the majority of cases, or on an exam, if you're stuck for an answer, go with any kind of trauma, including an infection. Okay, so let's talk about the process. Let's talk about what happens in the body when you have an absolute insulin deficiency. So the first thing that's pretty much key to DKA and different from HHS is that you don't have insulin in the body to suppress lipolysis. If you remember from one of the earlier videos, one of insulin's jobs is to stop lipolysis from happening. Remember, insulin loves to take glucose out of the blood and store it. And it stores it in 3 different places. It stores it in the liver as glycogen, it stores it in the fat cells as triglyceride, or it stores it in the muscle cells as protein, right? So if insulin is trying to get that blood out and store it in the fat cells, then it's going to stop or slow down lipolysis, which is the opposite, breaking up those fat cells and releasing that glucose back into the blood. Insulin doesn't want the glucose back in the blood. It wants to keep it in the fat. And so one of the things it does is it puts a stop to lipolysis. When there is no glucose to break down, or the body thinks there's no glucose to break down, then the lipolysis begins. There's no insulin to stop it, and so these fatty acids are released from the adipose tissue. And we know that when fatty acids are released from adipose tissue, you end up with ketogenesis, which is the creation of ketones. And on this hand, you have something really good happening. You have a creation of acetyl-CoA, which, if you remember from our metabolism video, is what the Krebs cycle needs to begin its process of creating energy. And so you do have some energy production going on, which is great. That's what we need in the body. Unfortunately, those ketone bodies are released. And when those ketone bodies build up and build up and build up in the system, they bring up those the hydrogen ion levels, and they cause acidosis, or an increase, well, it would be a decrease in the pH, I'm sorry. And so one of the very, very first symptoms or signs of DKA that you're going to see in a patient is ketonuria. If you look at this kind of drawing, you'll see that all the signs and symptoms are in these blue boxes here, and then the rest of these kind of black and white areas are just telling you how we get there. So again, hallmark symptom, hallmark sign of DKA, ketones in the urine, right? If you have all those ketones in your blood, they're going to be coming out in the urine. And then over here, we talked about we're going to have an increase in hydrogen to the point where we have a metabolic acidosis that occurs, or our pH is less than 7.35. You're going to see an increase in the anion gap. And that's because you have that increase of ions, you have that change in the pH level and all of the electrolyte differences. You don't really need to worry at this point to understand what an anion or anion gap is. Just understand that it will change in acidosis or alkalosis. And then one of the really, really important things to note is that one of the things that keto acids do is they actually consume bicarb. If you remember from the videos on pH, bicarb is one of the things in our body that works against acidity. So we have a carbonic acid that makes our body more acidic, and then we have bicarb that makes our body more basic. So if you've got a bunch of keto acids building up in the blood, plus those keto acids are consuming bicarb, you kind of have a double effect of an increase in acidity and a decrease in base at the same time. So you can understand how this has the potential for disaster. So let's talk about some of the symptoms that come out of metabolic acidosis. And remember, we don't have this in HHS. We don't have the metabolic acidosis, and that means we aren't going to have these symptoms that I'm about to talk about that are a result specifically of acidosis. Okay, so first of all, that acidosis disrupts the enteric nervous system, and that can result in a decrease in gastric emptying and sometimes ileus. And that is why patients develop abdominal pain, nausea, vomiting, and an increase in dehydration that has to do with what's going on in the digestive system itself. This abdominal pain, nausea, and vomiting is quite often the thing that brings patients into the ER. It's almost unbearable, the amount of nausea and vomiting that patients experience, and then again, that dehydration from losing all of those fluids. So that's one major symptom that comes about because of the acidosis. The body will try to compensate for this acidosis by blowing off CO2. And if you don't understand why that is, you got to go back to the video on pH and acid-base balance, and you can find out why there. But as the body is trying to blow off that carbon dioxide, to blow off some of that acidity, it's going to take deep, fast breaths. It wants to get as much oxygen in and as much carbon dioxide out as possible, because that carbon dioxide is going to increase that carbonic acid that's causing or increasing the acidosis. And this is why we have small respirations in DKA but not in HHS. Again, one of the other things the body is going to try to do with these ketones is it's going to try to breathe off some of those ketones. Those acetones will be excreted in the lungs. This is where you get that hallmark sign of diabetic ketoacidosis, which is that fruity or acetone breath. Let me tell you, that is a real thing. The first diabetic ketoacidosis patient that I had, the first thing that kind of alerted me to something going on was that the patient came in, was in his early 20s, didn't have a history of diabetes as far as he knew. He looked terrible. His lips were so dry. He looked like he had been throwing up. And so in Emerge, and the reason, part of the reason I love Emerge is that we get to follow directives, meaning that I can see that patient, do an assessment, and then decide to run certain blood work. And so immediately I'm going to pull your basic blood work plus do a urinalysis. And I remember after doing my assessment, I left and I had this, I don't know if any of you use a urine dip, but it's a way of getting some of that urinalysis information very quickly. So we send the urinalysis off to the lab, but we can dip part of it. And there's this little machine that gives us some information. One of the levels that can give you is glucose. When I picked up this patient's urine dip results and I looked at them, the glucose was so high that it was unable to calculate through that urine dip. And so that was my first kind of sign that something was going on that had to do with insulin and glucose metabolism. So I headed back to the patient and I began talking to him a little bit. And that's where I really started to smell that acetone breath. And then obviously putting 2 and 2 together, was very quickly able to determine that the patient was DKA. And this was, I think, my second or third day on the floor by myself. So it was terrifying. And thankfully, there were other people around who were very experienced. I love the fact that in the ER, you have other people to run things by, to talk to. You don't have to deal with any of this stuff completely on your own, not usually. Okay, so one of the other things that's going to happen as a result of this acidosis is we have a disruption in the kind of electrical impulses that are going or moving between the brain, the spinal cord, and the nerves in the body. And this is why patients who are in DKA will seem fairly confused and their body is a little bit, their muscles are weak. And eventually, if untreated, this is what is going to contribute to the patient entering into a coma. So be really careful with this, because this kind of disruption in signaling and the resulting weakness and confusion is very different from the neurological changes that you're going to see in HHS. There's a whole video on the difference between DKA and HHS that you can check out. It talks about that a little bit more in detail. For now, let's look up at some of the rest of these symptoms, these signs of DKA. So we talked about this absolute insulin deficiency and what the body is doing in terms of lipolysis. Let's talk about what's happening because of the rest of that glucose that's remaining in the blood. Remember, we have a lot of glucose, it's just not being used. And again, it's specifically not being used in the muscle and fat cells where those GLUC4 receptors are required for glucose entry into the cell. So the cells themselves, they think that they're starving. They're not getting any glucose. And that is what triggers the release of, even more counter-regulatory hormones. Again, because your body, your cells think they don't have enough glucose. So we need more glucose. And what hormones in the body are responsible for taking glucose out of where they've been stored and putting them back into the blood? And we've talked about that. It's these counter-regulatory hormones, glucagon especially, but epinephrine, cortisol, growth hormone, that should have a W in it, sorry about that. And what happens when we increase these hormones? We have an increase in serum, we have an increase in glucose in the blood. And the hope is that if the body is thinking, if I can increase the glucose in the blood, then I can increase the amount of glucose that's going into the cells, not knowing that the reason that the glucose isn't going into the cells is because it can't. There isn't enough insulin. So now we've got even higher glucose than we started with. And these are just, these two things down here are just showing you some of the ways the body is going to try to increase glucose in the blood. One of them is gluconeogenesis and glycogenolysis in the liver. The other is decreasing protein synthesis. In other words, normally the body would take those fatty acids and create protein and store that in the muscles, but let's stop doing that because we want to keep those fatty acids. We want to keep as much of that energy as we can. So these things are going to slow down right there. So now if you kind of look from all of the things we've kind of talked about, kind of scroll up here and you can see where this really high, this increase, this in blood glucose is coming from. Now, when you have an increase in a large increase in glucose in the blood like that, it's going to have an effect on the kidney. In one of the ways it does that is when your blood hits the kidney, and if you remember the kind of functional unit of the kidney is the nephron. The first part of the nephron has that glomerulus. Don't worry, this isn't something you need to necessarily know for this test. Definitely something if you're studying for NCLEX you can go and review in another video. So when the blood comes into the kidneys, it's going to be filtered, goes through the glomerulus and down into the proximal tubule. And in the proximal tubule, this is where normally most of that glucose that's in your blood is reabsorbed back into the body. Glucose is something we don't want to excrete from the body in urine. So a very, very, very large portion of your blood glucose is reabsorbed in the proximal tubule. However, the kidneys can only reabsorb so much glucose. So when your glucose gets to the point where it's very, very high, you will start to see this is what's the word? Not good enough. Effective. Well, this is not enough. And so you're going to see all of this, some of that glucose is going to escape, go through the proximal tubule, through the rest of that nephron and out of the body through the urine. And that is why when you have high glucose in DKA, one of the signs is glycosyria. In other words, glucose in the urine. You shouldn't see glucose in the urine. If you do, it is a sign that something is going on. So one of the other interesting things that's happening is when you have so much glucose in the blood. If you remember from our videos on fluid and electrolyte balance, let's say this right here is a blood vessel, and you have this increase in glucose in the blood. You remember we talked about how the larger proteins attract fluid. So the larger proteins, and I think what we usually talked about in fluid and electrolyte balance was albumin, and how albumin is a large protein and it pulls fluids out of the interstitial space and out of the cells and into the intravascular space. Well, the same thing sort of happens with glucose. Glucose is actually quite a large molecule in and of itself. So when you have so much glucose building up here, it actually is going to change the osmotic gradient, and it's going to start pulling fluid in from the cells and from the interstitial spaces. And then what happens to that fluid? That fluid is going to go again back to the kidney, and some of it will be reabsorbed, but it can't absorb all of that. It can't absorb all of that glucose anymore. So not only is the glucose going to come out, but all of that fluid is going to come out as well. When you have that kind of hyperosmolar state where the large molecules in the blood there's so many of them that they're pulling all that fluid in, that fluid has to go somewhere. and it's going to come out in the urine. And this is why we have the symptom polyuria. When somebody has very, very high glucose, they're going to have polyuria. You put that together and you end up with dehydration. And this is a very severe dehydration. Like I was talking about earlier, the patient that I saw, dehydration was extremely, extremely obvious. Even like cracked lips, skin turgor was terrible, so on. So we have severe dehydration. We're going to have all of these typical symptoms of dehydration. I'm not going to go through those because you guys know that stuff. That stuff's nursing 101. But it is important to know that now we have a decrease in the amount of blood. We're becoming hypovolemic almost. And so we have a decrease in the amount of fluids in the body. So we're going to have a decrease in the amount of blood that's perfusing the brain and the spinal cord and the nerves. Similar things are affected here and here. And this is where you do get some of that weakness, confusion, and then again, the risk of coma. Please, please, please go and take a look at the HHS video so that you know how this is different in DKA than it is in HHS. Really, really important. One of the other things that happens, and this is where a lot of people get lost. One of the other things that happens when you have severe dehydration is that it's going to alter the total body water or fluid content, and it's going to alter the ion osmosis, and basically you're going to end up with all kinds of electrolyte imbalances. So, I could go back. So you have all of these, which you should know about, we'll talk about, and then all of which results in polydipsia or lots of thirst. So that's where that other P comes in. Here we've talked about polyuria, we've talked about polydipsia, and we've talked about polyphasia. So back to the electrolyte balance. One of the major things that happens is, if you remember, most of the potassium in your body lives inside of the body's cells. Most of the sodium lives outside of the body's cells. Let's put it in here. That's your blood vessel. So because of the relationship between insulin and glucose and potassium, which we're not going to dive into today, it's enough for you to know that potassium is forced out of the cells where it normally lives. And when it's forced out, again, remember, we've got all of this stuff pulling fluids, and we've got diffusion happening, all kinds of changes in the ion osmosis and the osmotic gradient. And so you end up having potassium that is pulled out of the cells and ends up in the blood and in the intravascular system. So when the patient comes in, very, very often, and again, remember I said they come in and the first thing we're going to do is pull blood. When that blood work comes back, very often you will see a potassium that is normal to normal high. So you might see a potassium that is 4.9. You might see a potassium that's 5.6. And you're looking at it and you're thinking, okay, here you're thinking, okay, good, potassium's good. Here you're thinking, okay, we're a little bit hyperkalemic. What's going on? And I tell people this all the time. The first time I had a DKA patient, and I was working with another nurse, and she was very, very experienced. And we were at this point where we had pulled the blood work and we're looking through everything, and she's getting everything ready to treat the patient. And one of the things she does is she pulls out potassium chloride to give the patient. And I'm thinking, I'm looking at the blood work, and the patient's potassium level is somewhere here, maybe 5.5, 5.6. And I'm thinking, why is she giving this guy potassium? And it was so incredibly confusing. And I didn't ask in the moment because heads up, students, in those moments when there's so much going on, not the time to ask, right? So I waited till a little bit later and she explained it, but honestly, I didn't really get it. And it took me a little while to catch on, to really understand what was happening. So we had all of that potassium being pulled out into the blood. And again, we have all of this polyuria going on, right? And so a lot of that potassium is going to be excreted through the urine. And so sure enough, an hour later, when we took potassium again, which, just so you know, when somebody is in this kind of DKA, we are doing blood work constantly, at least Q1. And so we do the blood work again an hour later. Sure enough, our potassium is something like 3.4 at that point. So that's how fast that shift was happening, that potassium was being pulled out of the cells and then back out of the body through the urine. So this is a really important aspect of DKA to understand. It does happen with HHS as well. So it's a good thing to understand now so you don't get lost later on. Now, where is my polyphasia? So on top of that, one of the things that happens is the body is the hypothalamus senses that there is low glucose inside of the cells. And so that right there will trigger feelings of hunger or polyphasia. So if you look here, that's another one of our 3 Ps, right? And so that is where that comes from. It's the body's reaction to kind of the starvation of intracellular glucose. And then you can fix that later. So those are the basics. Those are the basics of So those are the basics of DKA. Really not as complicated as I think we make it in nursing school. I promise you that once you care for a patient in DKA a couple of times, you're going to get this stuff really quickly. In the meantime, this is definitely something that's incredibly important for tests and absolutely for the NCLEX, especially knowing the difference between DKA and HHS, and more importantly, knowing how to treat both of those. And we'll talk about that in the next video.